responded. The day court was just like, we're gonna continue, so. All right, let's talk about what you need to know from the lecture that we just finished, so things that you need to focus on. Make sure that you are able to identify what are some common symptoms of anemia in general, right? Make sure that you know dietary sources of the ones that are diet deficient. If I gave you a scenario, could you, with some like different information, determine what type of anemia it most likely is? Make sure you know the symptoms that are specific to each type, like B12 and pernicious or B12 and folic acid have some weird symptoms, so make sure you know those. For sickle cell, make sure that you know signs and symptoms. How do we diagnose it? How do we treat it, a vaso-occlusive crisis, and then what we monitor for acute chest syndrome. And of course, the two medications that you've probably never heard of until today. Hemophilia, make sure you know your Roman numerals, because they are expressed in Roman numerals. So which clotting factor are they deficient in? What are your signs and symptoms? How do you treat it? Okay. All right, what we're gonna do now is I'm gonna skip, there's several questions before these case studies, but the answers are in the speaker's notes, so I'm gonna leave these for you guys to do if you want to. But I am gonna go over the situational case studies briefly, because there's not answers to those on the PowerPoint. So all of these are gonna be some type of perfusion diagnosis, but they're not all gonna be types of anemia. So I'm gonna let you read through the scenario, and then I'll ask you some questions about it. So essentially, what do you think is going on? And then we'll briefly talk about how you would treat it, just to kind of review some of the stuff that you've already had and what we've talked about today. All right, there you go. That's a lot of stuff, so let me know when I'm good. Okay, everybody done reading? What do you think is most likely occurring? Hemorrhage. That if we had to classify as a type of anemia, we would classify as blood loss anemia. And if she is symptomatic and we were gonna present with a type of shock, this would also be classified as hypovolemic shock, okay? Tell me, so we can do a little bit of OB review, tell me what are some risk factors to the fact that she's having a postpartum hemorrhage?
The big baby.
Big baby?
Young.
19 hours later.
Okay, long labor, so big baby, long labor with Pitocin, all three of those, okay? What is the normal blood loss that we see after a vaginal delivery?
500
500 or less, we are currently at 1,300, so almost triple the amount that we should be having. What would you expect to see in her vital signs if I gave you vital signs? Tachycardia,
Low blood pressure.
blood pressure. So her blood pressure is still kind of holding on a little bit there. It's 106/70, but her pulse is 115. Could it cause a change in her level of consciousness? Yes. What do we want to do about it?
Massage the fundus.
Massage the fundus and
Give
then
her
give
some
some
fluid bolus.
medications. So fluid bolus, Pitocin bolus, massage the fundus, and use your backup drugs if you need to. Okay. What do you think is occurring?
Iron deficiency.
How do you know?
Very
Because the ferritin level is low. So what would we want to teach her to increase in her diet? Right, absolutely. So those things on the edge, the meats, certain vegetables, legumes, lentils, those type things would be helpful. We're gonna increase that in her diet. If for some reason we need to do supplementation, remember you can do it in a pill form, there's a liquid form, there's an injection, and there's also IV iron that we can give as well, depending on the patient. Would the MCV be increased or decreased with this type of anemia?
Decrease because it's micro.
Decreased because it's micro.
B12 deficiency.
It's probably B12. It could be potentially B12 or folic acid. You could make an argument for both of those. The fact that she's having some gait issues almost makes me think more B12, but one of the two, right? So we would need to do some additional labs. Would the regardless if it was folic acid or B12 or a combination, would the MCV be elevated or decreased?
Elevated.
It would be elevated. And we would expect to treat it by what?
Dietary.
Yep, either injectable B12 or dietary increases of B12 or folic acid, depending on which one was deficient. Miss Capeless, we just covered anemia, this does not seem to fit that. What do you think might be going on? Okay, what if I told you that there was an elevation in the D-dimer also? Does that help? It's a PE. What is her risk factors for it, or what is the most substantial risk factor? What? Yep, she's post-delivery, and we know that in the postpartum period, there's increased risk of blood clots. So she presents with sudden onset of shortness of breath and chest pain, decreased oxygenation, tachycardic on the monitor, and then if you did a chest x-ray and it was a PE, it's gonna come back essentially no findings. You're gonna have to do some additional testing, like a BQ scan or something like that. What are your treatment options gonna be? What's the least invasive thing that we need to immediately do? Okay, even more basic than that. Sit them up, so put the bed up, apply oxygen, and what type of medication, once we've confirmed that this is a PE, would we expect? Anticoagulants or? What's the other class that's a little bit stronger than anticoagulants? Clot busters, like thrombolytics, clot busters. Very good. If it is an ischemic CVA, what treatment plan would we anticipate? Medications? TPA. You would need to make sure that there's not any exclusion factors. I'm assuming that y'all, whatever what those are, so just make sure you review those. If this was your patient, do we expect them to have a low H&H? I mean, they're anemic, right? So we do expect that, but what would your treatment plan be?
Comfort, pain.
Okay, narcotics for pain. What else do we need to do? Oxygen, positioning for comfort. Okay, so potentially medications, but definitely hydration. So hydration, pain control, oxygen, comfort measures, and then we would give them a transfusion if needed. And then what is the complication that we have to monitor for after a vaso-occlusive crisis? Acute chest syndrome. Okay, what makes you think aplastic anemia? Do what? Okay, what also would be low if it was aplastic anemia? Platelets would be low, and red blood cell will be low, and white blood cell will be low. So we do have an H&H that's low, but we have a platelet count and a white blood cell count that's normal. So probably not aplastic anemia. Hemophilia. Did you say a hemophilia or aplastic?
I said aplastic.
Okay. hemophilia, we know we have an elevated PTT level. This is an 8-year-old. Unless they have some weird disease process that's being treated with heparin, they should not have an elevation in their PTT. So that would prompt us to think this is most likely hemophilia. What would we want to do as far as immediate treatment, like at the ball field? What could they do? Price, so pressure, rest, ice, compression, elevation. Once they get to the hospital, depending on the bleeding, we would also continue doing that, but we would also anticipate potentially giving desmopressin and get an actual diagnosis so we can do factor replacement. Okay, what do you think's going on? Stroke, okay. I would agree. What would be the highest, what would have a very high priority to complete once they get to the hospital? Why? Because it completely changes your plan of care. So a CT scan when you suspect a stroke is hugely important, because if it's ischemic, then we would treat it with TPA. But if this was hemorrhagic and we gave them TPA, we probably just helped them on into the grave, okay? So definitely need to make sure we do a CT scan first. And then if it was not hemorrhagic and they were within the window, they didn't have exclusion criteria, then we would do TPA. All right, 68-year-old patient had a CVA, they did TPA, his symptoms resolved, but now we're doing some additional testing. I wanna know why we would potentially be doing that testing.
To see if any damage was done to the heart.
Potentially.
See if there's any other clots anywhere else.
Potentially. What is one of the biggest EKG changes that can cause a CVA? What's the rhythm that can cause it? AFib and A flutter, okay? So one of the biggest risk factors for a stroke is AFib or A flutter, because the blood sits there and is stagnant and then it gets pumped out, and the first thing that gets perfused out of the right side of the left side of the heart is the brain, okay? The other thing is carotid duplex is gonna tell us about the carotid arteries. There could be plaque buildup, and if some of that broke off, it could cause an ischemic stroke. So both of those things are looking for what caused the stroke in the first place, to see if there's something we can identify. What do you think's going on?
A hemorrhagic stroke.
Okay, why hemorrhagic and not
I had
ischemic?
the severe onset.
Yeah.
of it.
So with your hemorrhagic strokes, there's definitely some things in here that would automatically make me think hemorrhagic over ischemic. So let's just talk about those for a minute. He has hypertension. He also he's very lethargic with a severe headache. That is gonna be more consistent with increased intracranial pressure, which we see more with your hemorrhagic strokes than we do with your ischemic. Not that your ischemic can't cause it, but if you've got a lot of blood pooling up in the brain, that's a fixed box, you get more of that. He also vomited, also common with increased intracranial pressure. And there's even some vital signs changes that make me think, there's something going on that's probably more of a hemorrhage. So they have that widening pulse pressure, their pulse is really low, on the low side of normal. So definitely makes me think this is probably hemorrhagic. And they're having some increased intracranial pressure. So that covers a little bit from your emergent lecture and a little bit from your perfusion lecture. What are some things, what position would we put somebody in that we suspect has a brain bleed with increased intracranial pressure?
Trendelenburg.
So what's that gonna do?
Puts
The
pressure
head
on
of it up, because you're trying to get gravity to work with you, not against you. If you Trendelenburg then, there's gonna be more pressure in the brain. So essentially, anything that you do with increased intracranial pressure is to prevent changes in pressure in the head. So that would include head of bed up. It would also include, you don't want them to cough, sneeze, bend over, vomit. All those things are gonna change the pressure in the brain and can cause more bleeding.
What would cause the respirations to be 32?
A lot of times that's gonna be part of that Cushing's triad that you see with the increased intracranial pressure, and it can cause the respirations to change. sometimes it'll list it as irregular respirations, it may not just say elevated respirations, but your Cushing's triad is what three findings? Did y'all go over Cushing's triad?
Black holes.
Okay, widening pulse pressure, a shortened or a, what's the word I'm looking for, oh my gosh. Narrow, that would be the opposite of wide. A narrow pulse pressure is seen with shock, a widened pulse pressure is seen with increasing cranial pressure. And then you also have bradycardia or low heart rate, and then irregular respirations is the other component of that. Anytime there's a triad, it's always important to know it, because
So
there's probably gonna be a test
irregular
question.
could mean elevated or
It could,
decreased.
yeah, or shallow even, yeah. Okay. Alright, what do you think's going on with this?
Internal bleeding.
Okay, internal bleeding. So if we had to classify it by today's standards, what type of anemia?
B12.
Mm-mm.
Blood loss.
Blood loss. Now may have some issues because I think we did, what kind of surgery? We did a colon resection, so we could have some issues later on, but currently blood loss. It could also be hypovolemic shock. It could, you could just classify it as a hemorrhage, so a lot of different descriptors there. What changes in their vital signs would support that we have bleeding?
Or abdomen.
Blood
Okay.
pressure, pulse.
Low blood pressure, increased pulse, I'd even take the respirations and definitely the O2 saturation, because I think he is on oxygen too. What is the significance of the abdomen being hard? What is the other word that I could use for hard abdomen? Rigid. Anytime you see rigid abdomen, you better take notice, right? It usually indicates massive internal bleeding or massive infection of the abdomen, usually bleeding, but it could be either or. So we don't use the word rigid very often. So if it is used or that it is described as that, then you can assume that we have a major issue, okay? The pale mucous membranes, a prolonged capillary refill time tells us that we're not perfusing properly. Then looking at his lab work, tell me if that H&H is significantly low. Yeah, so typically speaking, we would transfuse for hemoglobin less than 8, less than 7 in some circumstances. We're definitely meet that parameter. Why do you think his BUN and creatinine are a little bit elevated?
Filtration.
Because blood loss is gonna start to shunt blood. Just remember, anytime you have shocky type symptoms, the kidneys are gonna take a hit. Okay? First of all, tell me what rhythm we have.
Sinus tack,
Okay, sinus tach at
130-ish.
130. So we're not SVT, we're not above 150, so we're still sinus tachycardia at 130. Looking at the rest of the findings, tell me what is most likely occurring. Okay, I'll take infection, let's start there. Why?
Because she has to have a fever.
Because he has a fever and it's not like just a little bit, a touch of some fever, it's a fever, it's true fever, okay?
I would say
Could that contribute to his tachycardia? Okay. Is there a type of shock that is based with an infection? Which one is it? Septic shock. So this is septic shock, low blood pressure, high heart rate with an infection, septic shock. What lab would also be elevated with septic shock? I mean, obviously the white count, but what's the other one? Lactic acid will also elevate, okay? What do you do about it? Not a trick question, I just want you to think it through. Okay, so do we need a large bore IV? Times 2, right? What kind of fluids are we gonna give? If in doubt, always go isotonic. Probably lots of them, probably a couple liters at least. And then what do we need to give them to correct it? We need a culture, and then we need to immediately start broad spectrum antibiotics, okay? So you gotta culture first, but you wanna get those antibiotics on board as soon as possible, because we can only buy them so much time without getting that infection under control. Here we are. Alright, what rhythm do we have? It is sinus bradycardia. How would I know this is not a heart block? Okay, so make sure when you're studying that you go back and look what would indicate a heart block. Remember, your heart blocks are gonna be bradyarrhythmias, right? Essentially, that's what they are. But the way you're gonna know if it's sinus brady or is it like first degree heart block is gonna be that PR interval. This one is not a heart block, it's just sinus bradycardia. At a rate of 40. And with bradycardia, you treat it if they are they symptomatic?
Yes.
How do you know?
He's diaphoretic.
He's diaphoretic, he's pale, his O2 sat's down, his blood pressure's low. He acts like he feels like he's symptomatic, so that's good enough for me. Sinus bradycardia would be treated primarily with a first-line drug of atropine, which is what type of drug? Does everybody look at me in my eyeballs? What type of drug is
It's anticholinergic.
anticholinergic? Okay, atropine is an anticholinergic. What is your backup drug for Brady's? If the atropine doesn't work,
Glauco.
epinephrine is your backup drug. Yep. If this was a third degree heart block, would we push the atropine?
No.
What would you be doing? Saying a little prayer and hooking him up to the pacer, right? Okay. What if it was a second degree heart block?
You would still try to give atropine, but it
You
might
could
not work.
potentially, so in some cases, it's not usually first line, but in a pinch, they may try some atropine. If it's third degree, you're gonna go straight to pacing. If it's second degree, that's kind of that gray area. So first degree, you can try atropine, sometimes it'll work, right? Second degree is, maybe try it, maybe not. Third degree, don't even try it. It ain't gonna work, you might as well pace them. They got 2 feet in the grave, okay? All right, what do you think happened to Paw Paw here?
He over-medicated.
He's got some dementia, and he forgot he took his labetalol, and he took it some extra doses today. All right, questions for me about situational case studies. So the questions that were before the situational case studies are more geared towards what we covered today. The ones that are after are kind of a hodgepodge. There's some either 113 content, like DVTs and that kind of thing. The answers are in the speaker's notes for all of them. If y'all want to use those, you're more than welcome to do that. Moving on to section 1. I wish y'all could have seen the faces on the day cohort with some of these topics, so it is what it is. Alright, tell me what topics are on your recorded lecture to be covered for sexuality. Menopause, not a disease process, but it should be. Erectile dysfunction. STIs.
Complicated periods.
Okay, menstrual dysfunction. Birth control, one more.
And infertility.
Infertility, okay? So, all of these case studies, there's gonna be one per topic. So I'm gonna let y'all gander at what y'all think Mr. Stanley Williams has. Gonna go on a limb, guess? He has erectile dysfunction. We just don't know it yet, okay? Alright, so this is Stanley Williams. He's 46 years old. He's being seen in the clinic today for his annual wellness checkup. You have vital signs and a height and weight. Assuming that we do give him a diagnosis of erectile dysfunction, what risk factors have you already identified? There should be 2.
His age.
His age?
He's male.
Okay, 3. There's 3. He is male. His age? He's a little bit overweight. So if you mapped out his BMI, it's about 28, which puts him in that overweight category. So he has those things going for him, or against him, I guess. Alright, so after assessing his vital signs, you do place him in the room. You ask about current medications, any health concerns. He's accompanied by his wife. He gives you his medication list. And this is usually how this happens. You're like finishing up, and one of 2 things will happen. He don't mention it to you at all, and the doctor goes in, and then he acts like he told you when you really didn't tell you, and you're like, he didn't tell me he was having erectile dysfunction, I'm so sorry. Or you're about to slip out that door, and he says, by the way, I need to talk about this, okay? So here is my caveat to say, with any of these topics that we cover with sexuality, they all need to be handled sensitively. This is something that's hard for people to talk about, so if they've entrusted us with this information, we want to make sure that we maintain a non-judgmental attitude, okay? So he does tell us that he is having some issues with erectile dysfunction. looking at his medication list, what can we assume that he has a history of just based on his medication? Okay, hypertension, GERD, and then we probably need to do a little questioning on why he's taking Advil. If he's mentioning it, it's probably taking it pretty frequently, so why is he having to take that, okay? All right, so let's talk about erectile dysfunction in general and common causes, and then we will apply that specifically to him. So the high-risk age group for erectile dysfunction is
40 to
40 to
60.
70 is what most
70.
people say. At 70, probably everybody has a little issue there. How long should these symptoms be present for us to classify it as not just situational based? They need to be present for consistently for
3 to 6.
at least 3 months, okay? And he reports that his symptoms have been going on for 6 to 8 months. Looking at risk factors, I'm just gonna cover them in general and then we'll go back and see what applies to him. So medical risk factors could be like coronary artery disease or high cholesterol. Diabetes would be a risk factor. Prostate can cause some problems with erectile dysfunction. You could also have low testosterone levels.
Wouldn't that low pressure? Couldn't that-
Low pressure could definitely cause it for sure. For lifestyle, obesity, sedentary lifestyle, smoking or alcohol use. And I don't mean like occasionally drinking, but consistently doing so. For medication, blood pressure medications can definitely cause some erectile dysfunction, along with many of your mental health drugs. Some antidepressants, anti-anxiety, antipsychotics. It's always kind of a catch-22 because if you have someone that is depressed, they tend to have issues in this area. And then you put them on medications to make the depression better, but it doesn't fix this component. And this is something that would bring joy to their life, and so we wanna make sure that we do address if there's a medication component that we have some control over. Additionally, mental health issues like stress, depression, that type of thing can cause some issues with erectile dysfunction, along with spinal cord injury. So there's a lot of different reasons that we could be seeing erectile dysfunction in him or anybody else for that matter. Did I mention stress already? I did say stress, didn't I? Okay. All right, so knowing those risk factors, what are some questions that you would wanna ask him?
About his job.
Okay, he is the foreman of a very busy construction company and they have been very, very busy. Is that stressful?
Yes.
Absolutely. What else?
His like exercise level.
Okay, he does not have time. Work is exercise, that's what he is. He drinks occasionally but smokes a half pack to a pack a day.
Okay.
Well, there's at least part of the problem for sure, right? So doesn't really exercise much, does smoke, occasionally drinks, has a high stress job. So definitely some risk factors there. So the doctor comes in and he orders some labs. Hey, nobody laughs. I think this is aged out. I'm gonna have to pick somebody else. Y'all know who Marvin Gaye is?
Yeah.
Okay, see, y'all know. See, y'all should have chuckled a little bit. Anyway, so Dr. Marvin Gaye comes in and he orders some lab work. So I want to talk about why we would order this. So what would help to give us at least part of the picture of some things that could be causing his erectile dysfunction in the CBC? Or why would we do it?
The lipid would tell you he has high cholesterol.
Okay, lipid would tell us if we have high cholesterol.
Testosterone.
Could he have anemia and his fatigue be a contributing factor? Possibly. We also want to make sure there's not any infection, not usually a culprit, but could potentially be a problem. CMP is going to give you your electrolytes, but it would include a glucose level. It would also include your renal function, so that would help us out a little bit. Thyroid panel, because the thyroid, if they're hypothyroid, they probably just don't really feel like doing much of anything, so thyroid problems can contribute to this as well. Cholesterol, and then of course testosterone levels, if they're low, can decrease their libido for sure. All right. We give him a questionnaire, ask him to answer the question so that we can gauge how severe his dysfunction is. He's gonna be on the more moderate scale. You do not need to memorize this for the test. I'm just telling you there is a scale out there if we need to give them a screening tool for erectile dysfunction. So he does end up being more mild to moderate. And he does come back in, just kidding. These are his lab results. So I want you to take a minute and tell me, what can we conclude, knowing what we've assessed in him, his history, and his lab findings as being potential contributing factors to his erectile dysfunction? His testosterone level was normal, I just forgot to put it on there. Okay. Is it infection related?
No,
Is he anemic?
yes.
Yes.
Okay, not significantly so, but it could be a contributing factor. What about his glucose?
It's normal.
So probably not diabetic in nature. His BUN and creatinine looks fine, so not a renal culprit there. What about thyroid?
Normal.
Looks good. Liver looks good. What about his cholesterol?
It's a little higher.
So if I had to pick, if this was given to you on a test, you would say the two things that are contributing would be his H&H and his lipid panel, right? Both of those are out of whack and they can contribute. Now, knowing his history and what we've already asked him, what are some additional factors that are probably contributing to his erectile dysfunction? Stress,
Medication.
smoking, lack of activity, right? So now we're gonna kinda come up with a game plan for what we need to tell him to do. So, what do we need to tell him about the smoking?
Cessation.
Please stop, right? Please stop smoking, that is not healthy. What can we help to reduce his stress level?
You should get a different job.
He could get a different job. If that's not an option, we could teach him some coping strategies like meditation. The big one would be exercise, because he's a little overweight, so 2 birds, 1 stone. It'll help with the stress, but also help with him being a little overweight. So we're gonna encourage him to exercise to reduce his stress and to lose weight, improve his diet, because he hasn't been eating exactly like he should. And what kind of diet would he need to eat? Low cholesterol, because his
Low
cholesterol is
sodium.
high. Low sodium, because he has hypertension. And he's anemic, so what would we also increase in his diet?
Protein.
High protein or high iron levels, yep, there you go. So we do all the education, all the things. And he comes back in a couple weeks. His previous weight was 206, his previous blood pressure was 126/70. And he says that he has started eating better, him and his wife have been exercising together, and he's lost a little weight. So is he probably telling me the truth that he's exercising and eating better? Yeah, his blood pressure's down a little bit, his weight's down a little bit, so he's probably doing the things we ask him to do. However, he still is having some issues with erectile dysfunction. So now we're gonna move on to medications. Okay. Y'all ready for your instructions? Alright, so your erectile dysfunction meds tend to end, the generic name tends to end in FIL, F-I-L. Okay, always remember them, because you're filling up the penis with blood, which is how they get an erection. You'll never forget it again, okay? Alright, so Cialis, what's the other one? Viagra is the one that you hear a lot about. Now, that being said, if you have a patient in the hospital and they are on Viagra 3 times a day, I promise you it's not for erectile dysfunction. So what is the other reason that we give these? Vasodilators, we can usually use them to treat pulmonary hypertension. So they do vasodilate, they work well for pulmonary hypertension, so if they're getting it on a routine basis in the hospital, we are not giving them Viagra just because we think they have ED, okay? It was funny, I had a student, she's like, I just don't feel comfortable giving this in the hospital. I was like, I promise that's not why we're giving it in the hospital. We do not do all that in the hospital. Alright, so it can be used for pulmonary hypertension. It is a potent vasodilator. That's how it gets blood to where it needs to go. Okay? There is some education that we need to provide though. So with this one, they need to avoid alcohol. You do not want to give it at the same time as their antihypertensives. So they don't have to stop them, but they don't need to give them at the same time, because then you're going to get a substantially lower blood pressure. They need to change position slowly, because again, it is a vasodilator. Side effects, headache and dizziness related to blood pressure change. They absolutely do not need to use nitrates within, I'm gonna say 24 to 48 hours of using Cialis or Viagra. Some sources say 24, most say 48. I'll just give you the range. Because this medication does cause an erection, we always have to tell them if they have an erection that lasts more than 4 hours, that is a medical emergency and they need to seek help. The medical term for that is priapism. So if they have an erection that lasts longer than 4 hours, they need to go to the hospital. They also need to take this usually 1 to 2 hours before planned intercourse, but at least 30 minutes prior, so that it gets in their system and can work. The question we always get asked is this just gonna cause a spontaneous erection, and the answer is no. There has to be some stimulation for that to occur, so they can safely take it on the way home and be ready to go when they get there, okay? So that's what they, take it when they leave work, be ready when they get home. All right, any questions about, your erectile dysfunction meds? He comes back 2 months later. These are his follow-up labs. He is now 192 pounds, and his blood pressure this morning was 106/78. Has he been compliant with our treatment regimen?
Yes.
How do we know?
Weight loss.
He's lost weight, his blood pressure is better, his H&H is better, and his cholesterol is better. He has been a very good and compliant patient. He also has a great sex life. We take him off his HCTZ because he doesn't need it, because his blood pressure is actually a little on the low side. Any questions about erectile dysfunction so far? This is when I lost a day cohort, but it is what it is, we gotta cover this, so just bear with me. There are some other things that we can do for erectile dysfunction. Now, typically speaking, medications is what you're gonna see primarily used, but there's some other things that are available. So you can have penile suppositories, which is exactly what it sounds like it is. There's also penile injections. Those last for about an hour. As you can imagine, most men do not prefer that as the method, but it is an option. There's also penile implants. There's 2 types, one that we don't use much anymore. I've tried to even get away from it. I'm just kidding. Semi-rigid was the old type that we used to use, okay? It caused the penis to have a very semi-erect appearance, and so we don't use those much anymore because under clothes it still didn't look normal. And so now we use more of an inflatable implant. So that is surgically implanted. And then there's a rod that goes up the penis, and then there's a reservoir in the scrotum. So they can use that to inflate the penis, and then there's a valve that they can press that will cause it to deflate. So when they do not want to have sex, the penis looks very normal. So that is usually the one, if it's going to be surgically implanted, that they will use. The other one we just don't use much anymore, okay? The other thing would be a vacuum device with a ring, so that's the top right. So the way this would work would be a vacuum pump that essentially pulls blood into the penis, and then they would put a ring at the base of the penis to keep the blood there until they've had sex, and then they would take the ring off. The key is the ring cannot stay in place more than an hour. Okay? So you would use the vacuum to cause an erection and the ring to maintain it, but it does not need to be in place more than an hour. Okay? Any questions about different treatments for erectile dysfunction? Okay. All right, this is Miss Potter. She's 51. So what do you guys think she's gonna suffer with? Menopause. She is married to Frederick. They live on a farm. He has some health problems, but really all she has is a little bit of some low calcium that she takes a supplementation for. And she is being seen at her GYN office today because she just does not feel great. So after doing some questioning, we think she's probably in menopause or going through menopause. But let's talk about what that would entail. What is the primary age group to go through menopause?
45 to 60.
Okay, 45 to 60 or 48 to 55, somewhere within that age range. And by definition, this would be not having a cycle for how long?
A year.
A year, with no other known cause, right? There's not another reason that you're not having a period. For signs and symptoms, what are some signs and symptoms that we see with menopause?
Hot flash.
Okay, hot flashes, night sweats, insomnia, those kind of all go hand in hand. What else? Okay, mood changes, so they can have a lot of anxiety, they can definitely have some significant mood swings or depression. Somebody said it. Vaginal dryness, which leads to painful intercourse. They can also have an increased risk of UTIs and stress incontinence as well. They also can develop osteoporosis. It's just a great thing, menopause.
Mm-hmm.
All right, if they have a history of osteoporosis, they're going through menopause, or we're trying to prevent or treat osteoporosis, what do we need to increase in their diet?
Calcium.
Calcium,
And vitamin D.
Vitamin D. I'm gonna throw in adequate amount of phosphorus as well. And then what type of exercises do they need to do?
Weight bearing.
Weight bearing. So for osteoporosis, calcium, vitamin D, phosphorus, and weight bearing exercises. For symptoms, we're just gonna make sure we went through all this. So vaginal dryness, painful intercourse, stress incontinence, increased risk of UTIs, hot flashes, insomnia, night sweats can be brutal and severe to the point they have to get up and change the linens because they've soaked through their linens. And for mood changes, we're gonna do irritability, anxiety, depression, along with osteoporosis. Okay. These are her vital signs and her height and weight. Any red flags there?
Not really. I mean, she's a little overweight,
Technically, yes, but she looks pretty good, so we're gonna move on about that. She reports that she's had no period for 10 months, so is this technically classified as menopause yet?
Not yet.
Not quite. She says her periods have been irregular even prior to that, which is probably perimenopausal for her, and she has occasional hot flashes. The key here is that we don't typically put patients on hormone replacement therapy unless their symptoms are significant and impeding their activities of daily living. So that being said, would we consider putting her on hormone replacement at this point?
No.
No, but that doesn't mean we can't do some education about things that she needs to include or could potentially take over the counter. So, what do we need to increase in her diet again for the osteoporosis risk? Calcium, vitamin D, phosphorus, weight bearing exercises. We do know that soy can actually help some with the hot flashes, so she could increase soy in her diet. Chamomile can help with the insomnia / hot flashes. You can buy valerian root over the counter. It's in a lot of your sleep aids to help with insomnia. Ginseng will also help with symptom management just in general. And I'm gonna mention this one with a big star beside it. So if they're having issues with depression, they can take something called St. John's wort, but it does interact with a lot of medications, so we would need to check interactions before we told them to take that over the counter. We could also tell her to limit caffeine and alcohol, dress in layers, cool liquids before bedtime, and then if she's having vaginal dryness, what type of lubrication should she use? Always water-based, like KY jelly, not a petroleum-based lubricant, okay? So we send her home with all of the good education, and she comes back 4 months later and she's like, hey, we gotta do something about this, right? I don't feel good, I am having significant mood swings, severe night sweats and insomnia, painful intercourse. So now she wants to discuss hormone replacement therapy, which is what we're gonna do, okay? So let's talk about the two different types of hormone replacement therapy. If they have a uterus, which she does, they will need to be on combination therapy with estrogen and progestin or progesterone. The progestin or progesterone is what helps to prevent uterine cancer. So if they have a uterus, they need both, okay? If they do not have a uterus, they will do estrogen only therapy. So before we initiate that, we would need to know their past surgical history. If a patient has a hysterectomy, does that automatically put them into menopause, yes or no?
No.
No, only if
They remove the ovaries.
they remove the ovaries as well, okay?
That's the reason why a lot of times they just leave them.
Correct, yeah, cause it's a lot better, cause if you take ovaries out, that's essentially throwing them into menopause with no warning. Those patients will need hormone replacement therapy or they will be stir crazy for sure. Alright, looking at the risk. So when we put somebody on hormone replacement therapy, the good thing is it does decrease their osteoporosis risk because you're replacing that hormone, but it does have some risk factors of its own. The big one is gonna be clots. So hormone replacement therapy can cause them to have MIs and strokes and that kind of thing, although not as common and definitely not if we're using it for a short period of time. But we're gonna go with blood clots, heart disease, especially if therapy's over a long period of time. And then there's some research that does support that it can increase the likelihood of certain types of reproductive cancer as well. So it's not without its drawbacks for sure. So for that reason, we typically try to use the lowest dose that we can to maintain, to to decrease their symptoms for the shortest period of time. So the current working standard is if they're using combination therapy, we like to get them off of that within 5 years, because after that period of time, you start to see some of those side effects kind of come up. If it's estrogen only, 7 years. So 5 to 7 years after they've been on it, we need to be really looking at, do they still need this or not? And we typically reevaluate that about every 6 months or so. So she is given a prescription for Primpro to handle her symptoms. She stays on it for about a year and then comes off of it. Okay. Questions about menopause? This is Bella. Bella's 15. I'm gonna go ahead and tell you Bella has primary menstrual dysfunction. Okay. So there's 2 types of menstrual dysfunction. There's primary and secondary. Primary means, hey, her periods are rough, but there's not any pathological cause for that. She just has very heavy or painful periods, I guess would be a better way to put that. So she reports that over the course of the last few months, she's begun to experience increased pain and fatigue. She's also started to have headaches with her cycles and a lot of cramping that often prevents her from being able to go to school. So her mom is here with her today asking about what they can do to help improve her symptoms, and those are her vital signs findings. Any red flags in her vital signs? Would we expect any? Probably not at 15. All right, let's talk about some things that we would discuss with her. So this is probably gonna be a little bit off in left field, but it's a good way to pull some old content. We would probably go ahead and have a conversation with her about the Gardasil vaccination because she's in that age range. So we could talk about that, so we'll just talk about it. What is the Gardasil or the HPV vaccination meant to decrease the risk of?
Cervical cancer.
Cervical cancer and genital warts, okay? So the HPV strain will usually cause one of those 2 things or can potentially cause one of those 2 things. We can usually start those doses, or what's the prime age that we would start the HPV vaccine? You can start as early as 9, usually it's about 11 or 12, and it's gonna be a series of 2 to 3 injections depending on their immune status. So 2 for most people, if they're immunocompromised, it's 3. Current recommendation is for both male and female. All right, so we ask her, or what are some questions we wanna ask her about her symptoms or just in general because of her age?
Sexually active.
Okay, are you sexually active? When was your last menstrual cycle?
How long was it?
How long was it?
How heavy it was?
How heavy it was? Is it regular? Did you take that one? Did you have any nausea and vomiting? And the other one is, what do you do for the pain? Right? What are you currently doing? Can her mom stay for this conversation?
If she allowed.
Yes, as long as the patient's okay with it. If there's any question on that, we usually ask them to step out, because if their mom's staring at them, like, you don't want me to stay. I'll tell y'all, it wasn't funny at the time, it's funny haha now, but my kids don't, when they get sick, they go big. My son had meningitis, and so when we couldn't really figure out what the culprit was, they started asking like lots of invasive questions, and I was like, I'm gonna step out. And he's like, no, it's fine. And I'm like, no, I do not need to know about your sexual history. You are my baby, and I'll be out here, y'all come and get me when you're done. So usually they're gonna be more open to answer questions if their parent's not sitting there right in front of them, so. All right, so with her, she says her last menstrual cycle was a couple weeks ago. It is regular, it usually lasts 5 to 6 days. And the only thing that she's been taking for pain is Tylenol. Okay? So, we went ahead and drew some labs just to be thorough, but the only thing that came back a little abnormal was her vitamin D, and she was slightly anemic. We give her a diagnosis of primary menstrual dysfunction, and we start to do our education. So instead of Tylenol, what should she be taking?
Ibuprofen.
Ibuprofen is preferred. We typically tell them if their period's really regular and they know when it should start, to start the ibuprofen the day before their cycle should start, and take it pretty much around the clock, at least for the first few days of their cycle, so that medication stays in their system. That'll help a lot with their symptoms. Okay? There's also some research that says carb loading at the beginning of your period may be helpful. That's what they tend to crave anyway. So you can try that to see if it manages symptoms. For her specifically, we're also gonna increase her calcium and vitamin D, since her vitamin D level is a little bit on the low side. She can use a heat pack to her abdomen or her back. She does need to make sure that she's drinking plenty of fluid. And although she doesn't wanna exercise, exercise will help with symptoms as well. I do wanna talk about one other thing associated with periods. I wanna talk about PMS versus PMDD versus primary menstrual dysfunction. So this is the way it makes sense in my head, right? Primary menstrual dysfunction is a lot of the physical symptoms that they complain of. PMS is a lot more about the emotional or the mood swings or the mental health component of that. And just like when we talked about with baby blues versus postpartum depression versus postpartum psychosis, there's gonna be different variants of it. So PMS is gonna be, hey, you're getting through the day, but you're probably having some emotional lability. You could even be having some mild anxiety. That's typically managed on a symptom basis. Once it turns into PMDD, that's a little bit different, okay? So PMS stands for what?
Postmenopausal.
Premenstrual syndrome, right? What does PMDD stand for? Who knows, right? It's kind of a newer term. So premenstrual dysphoric disorder. It is where they're not able to control their emotions. They're probably not getting through the day very easily. They usually have very extreme mood swings, a lot of anxiety, like severe anxiety, and they can also have some suicidal thoughts with this one, and they tend to be very angry. They can have a lot of anger management issues. If they are diagnosed with PMDD, they typically will place them on SSRIs. So PMS is gonna be the milder form, and then PMDD, they typically will treat with medications at that point. So we go with primary menstrual dysfunction. Moving on to, secondary menstrual dysfunction. This is Shelby, she's 40 years old. She is presenting to the clinic today for menstrual dysfunction. She reports that over the last several months, her periods have become very heavy. She reports that she is chronically fatigued and has a hard time finishing her workday and activities with the children. Just to review, she has several children. She is a gravid-4 parent of three-term deliveries, all three living. Her last baby is 3 now, and she did have a tubal ligation after that delivery, okay, just FYI. What are some assessment findings? So we're thinking she's probably got some anemia, right?
Mm-hmm.
What are some assessment findings that would help to support whether or not we think she has some anemia? What would we want to assess?
Or mucous membranes.
Okay, they're pale, slightly elongated,
Or skin.
okay, she's pale.
She's also.
She also fair complected, but she's also a redhead. I look at this picture, I'm like, I bet you had a postpartum hemorrhage. Your redheads do tend to bleed more. It does take more anesthesia for them as well. That is not a false statement. All right, secondary menstrual dysfunction usually happens between the ages of 30 to 50, and it is gonna be heavy bleeding with their periods that's associated with some type of pathology. So it's secondary to something else going on. So some common things that can cause this would be endometriosis. They could have a tumor. They could have pelvic inflammatory disease, or they could have fibroids. The medical term for fibroids is leiomyoma. Do her vital signs support that she is having heavy periods and is anemic?
No. I mean, not really. Okay.
Could it? Maybe.
Might be leaning that way.
Might be leaning that way. So her pulse is a little bit higher than I would expect. Her blood pressure is slightly lower than I would expect. We would probably tend to see that if they were anemic. The doctor goes ahead and orders a CBC, a CMP, an abdominal ultrasound, and a pap smear and culture. Why do we do the CBC?
To see she's anemic.
Or
See how anemic she is. You could also look for infection. Why would we do a CMP? Because it's always a good thing to do. I mean, there's really not anything specific. We need a baseline, so if there is some abnormality, we would know how to dose medications, that kind of thing. Why an abdominal ultrasound?
To see what the pathological thing could be.
Yep, so tumors or fibroids would show up on ultrasound, and then why pap smear and culture.
To see if it's PVP.
To see if she has.
Yep, see if she has HPV or cervical changes, but also the culture would tell us if she has gonorrhea or chlamydia, which could lead to PID, so it would help us to determine the cause. So we go ahead and we complete all of those things, and she comes back 4 days later, and these are all your findings. I'm gonna give you a minute to kind of go through them and see. So you have your labs on the left, you have your pap smear in the middle, and then you have your ultrasound on the right-hand side. Is she anemic?
Yes.
Is she significantly anemic? She is, yep. Everything else looks okay. Her calcium's a little bit low, but everything else looks pretty good. What do we think about her pap smear and culture? The one in the middle. Can we rule out that it's gonorrhea or chlamydia?
Yes.
Okay, and her HPV was also, her pap smear was fine. They showed no signs of malignancy. But when you get to the ultrasound, what does she have? Fibroids. So it is likely that her heavy cycles are directly related to her fibroids. And since she has already had a tubal ligation, she does not desire to have any more children, they make the decision together to do a hysterectomy. So we will pick back up on her when she does a hysterectomy. I did want to take just a minute to discuss fibroids versus endometriosis, just so you know the difference, okay? Fibroids are gonna be non-cancerous benign growths on the uterus that will cause increased pain and bleeding, and they are more common in the African American population. So fibroids are not cancerous, but they can definitely cause some issues for sure. Endometriosis is where the lining on the inside of the uterus has been an overzealous producer and it goes elsewhere in the body. So instead of those little cells being confined to the uterus where they're supposed to be, they're elsewhere. Usually around the fallopian tubes or the ovary, but you could also find them in the intestines. There was also like a medical show where they found some endometriosis cells in a thigh because she kept having chronic thigh pain around her cycle. And that's what it was endometriosis that had migrated. That's not common, but it was interesting. With endometriosis, what happens is those cells tend to go through a mini menstrual cycle. So they will develop these little bluish black cysts from the bleeding, but usually the patient will complain of severe pain. Their cycles are usually very irregular, and endometriosis can lead to fertility issues as well, so it can be a culprit for fertility. The highest incidence of endometriosis usually kind of coincides with secondary menstrual dysfunction, so usually between the ages of like 25 to 40. Treatment for endometriosis is usually gonna be birth control to help regulate their cycles and their hormones. But obviously if they're trying to get pregnant, they can't be on birth control. Endometriosis can cause infertility, but should they get pregnant, their symptoms usually resolve during pregnancy because they're not having a menstrual cycle. So we'll get a reprieve from symptoms. Alright, so Shelby comes in the morning of surgery and these are your labs. If this was her lab work, what would your nursing action be?
Probably to report that she should not go to surgery.
Yeah. So we would want to notify the healthcare provider based on what lab findings? Okay. So her hemoglobin and hematocrit are significantly low, transfusion levels low, right? And when you look down through here, she also has an elevation in her PTT level, which would be abnormal. She does not take heparin or anything like that. So we call the healthcare provider and we do some really good communication using what technique? SBAR technique. And he says, let's do this. Let's admit her to the floor. I want her old records because if we questioned her a little bit more, she did say that she did have a postpartum hemorrhage the last time and they did some additional testing, but she never heard anything back from it. So he says, let's go ahead and get her old records. Let's admit her to the floor and I will put in orders. So he puts in orders, and these are your orders. Once we look at her stuff, we find out that she really has something called von Willebrand's disease, which we just talked about. So once we know that, it does change our plan of care a little bit. So Desmond Preston we'll talk about in just a second. She's gonna get Ann set up before she goes to the OR in the morning, assuming that she's stable to do so. We're gonna give her some lactated readers to keep her hydrated overnight, repeat some lab work, give her 2 units of packed red blood cells. We're gonna go ahead and do preemptive factor replacement now that we know what the culprit is. And we are going to put her on a regular diet with being NPO after midnight. What is desmopressin? What does it cause the body to release?
Iron.
Mm-mm.
All the factor eight.
Von
8
Willebrand's
and
and-
von Willebrand's. So it can be used for this patient. So we're gonna do a preemptive strike. We're gonna do desmopressin and factor replacement along with the blood transfusion, okay? She's probably gonna feel like a whole different person in the morning. All right, assuming that she is 60 kilograms in weight, calculate how many micrograms of the desmopressin we need to give. You would take the 0.3, you would multiply it times 60, and you're gonna get 18. So we calculated the dose of desmopressin at 18 micrograms. Now using your label, tell me how many milliliters you would need to give the patient. Round it to the nearest 10. How much you gonna give? I was like, I don't know what it is. It is 4.5. So we're gonna give 18 micrograms, which is 4.5 milliliters. I'm putting this on here because if you saw similar math, could you do it on the test? When your brain's not fried and you hadn't already had a test. Okay, perfect. We'll go with that, we'll go with that. All right, we're gonna do a transfusion on her. So tell me, what do I need to do prior to going down to get that blood? Vital signs?
Have cross match.
Okay, type and cross match. Informed consent. What do I need to hang? Normal saline on what type of tubing?
A Y.
A Y set, blood administration set with a filter, right? How many units of blood can I give on that one Y set? Max is 2, you can give up to 2. And what would I want to monitor as far as signs of blood transfusion reaction?
Usually it's fever, tachycardia.
Fever.
first.
Tachycardia, chest pain, flank pain, blood in the urine, so something that's abnormal. Anything that feels weird, she needs to let us know, okay? All right, so we do all the things we're supposed to do, and this is her lab work on the morning of surgery. Her previous H&H was 7.6 and 24. Do we feel like she is safe to go to surgery at this point?
Yes.
Yes, very good. There is your pre-op checklist, should you need a refresher on it from 113. I'm not gonna go over it, but that's what we would need to do to her before we got her ready for surgery. But let's talk about types of hysterectomies. So there is a type of hysterectomy called a lap-assisted vaginal hysterectomy. Lap-assisted meaning we use the laparoscopic tools where they do put gas in the abdomen so they can see. So anytime it's a laparoscopic anything, you do have to worry about gas pain after surgery. But we sometimes do a vaginal hysterectomy because the recovery time is so much better. So instead of having a large incision to the lower abdomen, they will use the instruments and detach the uterus, and then they will just remove it from the body through the vagina, okay? Now, in her case, because she has such a large fibroid, that's probably not an option. So we would probably do a total abdominal hysterectomy, meaning there's gonna be an incision to her lower abdomen. If it just says total abdominal hysterectomy, they took the uterus, okay? If they took the tubes and the ovaries, then it adds some pizzazz to the title, okay? So if they took everything, it would be a total abdominal hysterectomy with bilateral salpingo oophorectomy. Yeah, I know. It is kind of my favorite thing to say though. Pretty fun. So, in this one, they took everything. did a bilateral salpingo oophorectomy, will she go through surgical menopause?
Yes.
Yes, because we took the ovaries. We did not do that to Shelby, we just took her uterus because it was the problem. What would be a reason they would take everything?
Cancer.
Cancer.
Yep, cancer is usually the reason.
Can the patient elect, like if they're worried about cancer, can they elect to have everything taken out?
Probably, I mean, I don't know that a surgeon wouldn't, they would likely accommodate that if that's what they wanted. With the understanding that you're gonna be on hormone replacement therapy and all those things, because usually it's just not a gradual thing, and so they usually do require hormone replacement therapy for a while. Alright, so she comes back to us post-operatively with the following orders. We're still gonna keep her on IV fluids. Her liquid diet may advance with flatus. Flatus is what? Passing gas. Why? We wanna make sure they're passing gas.
Make sure everything's working.
Because we just put her to sleep and we mucked around in there, and so we wanna make sure everything's working. She has morphine, Toradol, and Percocet ordered for pain. Why would we have 3 different things ordered?
Different
Level.
pain levels.
Different pain levels. So which one we typically use for more mild to moderate pain? Toradol, especially if they don't wanna be sleepy. So in her case, instead of it being PRN, they're gonna give scheduled doses. Cause what we found is if we give them scheduled doses of Toradol, they don't usually require as much narcotic to keep their pain under control. So sometimes we'll see it ordered for so many doses. We can give Percocet, which is gonna be a PO medication that has what 2 types of drugs in it? Tylenol and a narcotic, okay? And then of course morphine is a narcotic, so it would be used for severe pain. Just remember, if you have a combination drug like Percocet, there's almost always gonna be a Tylenol order too. Just don't overdose them on Tylenol, so just be mindful of that, okay? We're gonna give her some iron to build her back up, some Zofran if she's nauseous, and we will continue the Ansef for a couple more doses just to make sure she's covered from that standpoint. For your post-op care, I did go ahead and put this in there. That's gonna be your post-op complications. I'm not gonna ask you that on this test, but it is a good review, so you have it as a frame of reference. She, however, did beautifully. That is her incision. It looks fantastic. She stays with us for a couple days and she goes home and recovers without any issue. Okay. Alright, so what does that leave us to cover? I think we have 2 or 3 things left. 3. We have STIs. I keep forgetting about STIs. So we have STIs, we have infertility, and we have birth control. Okay, do y'all want a break? Take about a 10-minute break, stretch your legs, and then we'll come back and finish up.